identify the examination being requested. Instead of saying flat plate of the abdomen or KUB, you put their abdominal X-ray. I consider that. So I gave you this. This is the right psoas muscle, okay? And then this is the shadow of your right kidney, but what I gave you was the shadow of your left kidney, okay? That's not the spleen. The correct answer there is that's the left kidney. And then this one, just right below your right hemidiaphragm, that is your liver, okay? And then I gave you this bone here. This is your left ilium, and then the left sacroiliac joint. Okay? So these are important landmarks. So when you see this, you don't see both diaphragms, so this is more of a KUB examination. Plain KUB, okay? Because the pelvis is fully visualized. Okay, the symphysis pubis, I gave you that, the symphysis pubis, that's an important landmark. Okay? So, again, as you can see this is the shadow of your spleen. So, this one would be, the more prominent one would be your left kidney. Okay? Okay, so this is the shadow that I did ask in your exam. Just right below the right hemidiaphragm, I put an arrow here. So this is the shadow of your liver. As you can see, that's the liver X. That's not the costophrenic angle, but that's the liver X. Okay? Then I gave you this shadow, but this is more prominent. This is your transverse colon. But anybody who answered large intestine, colon, that is considered. That is also correct. Okay? So, your guide here, anatomically, the large intestine would be seen peripherally. Okay? Cecum would start on the right lower quadrant going up. That would be your ascending colon. It would end on the hepatic flexure, and then it traverses your abdomen, so that is your transverse colon. It goes higher. So the splenic flexure is higher as compared to the hepatic flexure, anatomically, okay? And then you go down, that's the descending colon, and then you go to the sigmoid, and then you go to the rectum, okay? So the more prominent one would be the transverse colon. So when I put the marker at the center, that's more of the small intestines. Because anatomically, the small intestine is enclosed by your large intestine. Okay? Same is true radiographically. Okay? Same is true radiographically. So, your guide here is your basic anatomy. So, what's the difference of your large intestines and your small intestines? Aside from their location anatomically, you would appreciate haustra with your large intestines and valvula in your small intestines, connivientes. Okay, so do not interchange that, because your haustra is very, very much visualized in your large colon. And in cases of small bowel obstruction, you would appreciate those valvula connivientes. It would appear as a coil of spring sign. Okay? So again, this is your KUB. The kidney is very prominent. This could be a nephrogram film. This could be immediately right after the injection of a dye during your IPP examination. Okay? Some did answer venous pyelogram. I did consider that. Okay? So, this is the shadow of your right kidney and this is the shadow of your left kidney. This could be your nephrogram effect. This could be the second film of your IPP examination. Because the first film would always be, in any special procedure, the first film would be your scout film. Okay? So since this is, the kidneys are very much prominent, they are well appreciated, and it looks radio opaque. That could be the effect of your contrast material. Okay? Because with the use of contrast material, the kidney, ureter, and the bladder would appear radio opaque. Okay? So again, another important would be that as your T12 start counting with your reference of your last rib, because the last rib is always attached to your T12. So 1, 2, 3, 4. The one I gave you, the L5, is not actually well delineated. Hindi siya talaga buong buo. Pero that is next to L4, kaya you are obliged to answer that is L5. Okay? Seldom we would see radiographically that there is the absence of L5. Okay? So, in almost all, L1 to L5 is complete. So, kahit hindi mo na siya po makikita, that would be L5, and then next to L5, that would be already your sacrum. Okay? So, this is the KUB film. So, flat plate of the abdomen is another examination wherein you should visualize both diaphragm. Okay? So, KUB and flat plate could not be interchanged. Okay? But KUB and flat plate could be named as abdominal X-ray examination. So those who answered both abdominal X-ray, I consider that. Okay? Because you're right, both are abdominal X-ray. Okay? The only difference is that in KUB, the diaphragm usually is not visualized. In flat plate of the abdomen, both diaphragm should be appreciated, and there is a cut off here on the pelvis with flat plate of the abdomen. Okay? Okay. So, what are the gas pattern? Again, I gave you this. The Magellan glass or the gastric bubble, it's always on the left. Those who write left gastric bubble, left Magellan glass, I still consider that. Bali, cross out ko lang yung left. Okay? And then some would answer left. Instead of saying left kidney, some wrote right kidney. I still gave you 0.5. Instead of getting the whole point, I gave you 0.5. Okay? And then here usually small bowel, small amount of air. So air usually is more on the large bowel. Okay, so you would see here, this is your cecum, this would be your ascending colon, and then biglang bumaba, that would be your transverse colon. Nagsasag yung transverse colon. And then that would be your splenic flexure, and then bababa siya, that would be your descending colon. Okay? So, as you can see, the gas pattern could be seen peripherally. It's not at the center. Because it says there, the small bowel, there would be only small amount of air. Not unless there would be a small bowel obstruction, you would see plenty of air in your small bowel. Okay? So, adynamic ileus, so this is paralytic ileus. This is due to the paralysis of intestinal musculature. Okay? This is seen in the absence of peristalsis. And in any form of pain, you would appreciate ileus. Okay? So when patient would come at the ER, say for example, beyond midnight, complaining of extreme right lower quadrant pain, then instead of asking for an ultrasound examination of the appendix because you're considering acute appendicitis, you could ask for KUB examination. Okay? And then look for a localized ileus at the right lower quadrant area. That could be a sign or a subtle sign for your acute appendicitis. But please do not rely so much with your radiographic examination. But instead, you have to correlate your radiographic films together with your history, PE, and laboratory findings. Okay? So PE, or your history, so you have to visit the initial location where the patient did experience pain, usually epigastric. Then it would radiate down to your right lower quadrant area. Okay? And then do not rely so much with diarrhea or constipation now, because there's no pathognomonic criteria that in acute appendicitis it's more of diarrhea rather than constipation. Before, it used to be meron, pero nowadays, hindi na. If you're going to read old books, they would consider diarrhea is more associated with acute appendicitis. But nowadays, hindi na siya reliable. The more reliable examination now is you have to have your CBC. Titingnan nyo kung may leukocytosis, kung increase ang WBC, and the other examination would be your, aside from CBC, what other laboratory examination is being requested in your aid for the diagnosis of your acute appendicitis? Aside from CBC, what else? Usually, the surgeon would ask for urinalysis. Okay? Because they're ruling out UTI. Okay? That's one of your differentials. Okay? And then, as I've said, even though you have your laboratory findings, you have to include also your PE findings. So what would be your PE findings? Direct tenderness, on the right lower quadrant area, rebound tenderness. And how would you elicit rebound tenderness? Okay. You do it on the other side, press, and then release, and then ask the patient if the patient did feel some pain on the affected area. But you're doing the examination on the unaffected side. And then, without doing your history or without doing your PE, there is such a thing. I don't know if you have read it in your Swartz, or what's the other book in surgery? Swartz and Sabiston? Anybody who's reading Sabiston? Swartz lang? Is still yellow on Swartz? Okay, Sabiston is brown. Pero mas makapal ang Sabiston, pero mas simple ang presentation. Have you encountered in your readings yung AP walk? Usually, when you see your patient coming at the ER, nakayuko siya, leaning on the affected side. The patient would prefer to something like nakabow siya. Kasi once na in-straighten niya yung i-upright niya yung posture niya, na-stretch mas masakit. The patient would feel more comfortable pagka medyo yuyuko siya. So we call that, when we were interns, that's the typical AP walk. Nagpupustahan na kami niyan. Nasabihin namin, ayan, o-operahan yan. Kikita na naman yung surwano. And true enough, pag ginawa na namin yung laboratory findings together with the history, PE, and your X-ray, in some institution, there would be 24-hour service of your X-ray department. So ultrasound would be available 24 hours, 7 days a week in some tertiary hospitals. Okay? So people with money would go to tertiary hospital in the metropolis. So, kaliwaan yan, we would request for ultrasound of the right lower quadrant area, specifically the appendix. Okay? So, this is an example of your paralytic ileus. So, as you can see, wala na yung pattern ng colon. Di ba? Sabi natin, yung pattern ng colon, usually on the periphery, going up, that would be your ascending, and then transverse, and then descending. And in here, you could see a loop of gas shadow. Okay? So, this is considered actually as, normally yung mga radiologists would read this ileus. So, this is not really very, very significant. Parang napaka-general nito. Anybody who's experiencing pain, kahit toothache lang yan, pa-flat plate mo, may ileus. Okay? So, what's important is, you have to do your physical examination. Okay? There you are, another picture of your gas-filled bowel. So, again, hindi na lang siya sa periphery, nagsisigsag-sigsag na siya. Okay? And then, you could appreciate the simple haustration. In between, parang may mga guhit na puti. Very faint. Pero still, you would appreciate that one. there you are. This one is more of a generalized ileus. So the abdomen is almost filled with gas-filled distended bowel. Okay? With this supine film, you cannot establish your diagnosis with obstruction. For you to establish your diagnosis of an obstruction, you have to do an upright film. Okay? And then, in an upright film, you have to observe the air fluid level. Okay. Then the air fluid level would come in different sizes. And then usually it would appear as a step ladder sign, parang stair shaft. So this is an illustration of your small intestine. So normally it should be 3 cm. If it goes beyond that, then that is already abnormal. Okay? Again, there would be valvula coniguientes. Okay? Mas closer ang spacing niya as compared to your house drum. So, if you're going to measure that, you just use your ruler. Talagang, yung 3 cm nun sa ruler, dapat 3 cm din siya radiographically dun sa film. Okay? So, this is the sentinel loop. A sentinel loop is distension and or fluid levels near the site of inflammation. So usually sentinel loop is seen in cases of pancreatitis. This is one of the signs seen in pancreatitis, acute pancreatitis. There are different signs that can be observed in acute pancreatitis, and sentinel loop is one of them. But this sentinel loop is not pathognomonic to pancreatitis. Always remember that. Okay? This is the appearance of your sentinel loop. Parang inverted U-shape siya. Okay? Parang it's just like a magnet. This is the North Pole and then probably this is the South Pole. Okay? Take a look and then try to compare this later with your coffee bean sign shape in your sigmoid bulbous. They're totally different. Okay? So, here, this is your sentinel loop in pancreas. So, you try to see where is the sentinel loop located. Is it centrally or peripherally? Okay? Sabi ni doctor, centrally, what would be your basis? That the sentinel loop is seen centrally. That's very good, doctor. You're telling this point. Okay? Always remember, point of reference, the center would be your spine. Not unless you have scoliosis or kyphosis. Okay? So, as I said, there would be other different signs that would be associated with pancreatitis. So, one would be sentinel loop, inverted U, and then this one is the colon cut-off sign. So, this could be your transverse colon, and as you can see, there is a cut-off. Hindi na siya tumuloy hanggang papuntang splenic flexure. But again, this is not a pathognomonic sign of acute pancreatitis. Here is the example of your colon cut-off sign. Buo siya and then nag-cut off. So the cut-off could be located somewhere else. On the first film, the cut-off sign was seen on your transverse colon, this time on the descending colon. Okay? How would you know that this is your colon? As I've said, anatomically, it is seen peripherally. Okay? There's no gas, more peripheral to your gas shadow. So you have to assume that this is your colon. Okay? Aside from the colon cut-off sign, another sign would be your pleural effusion. Again, you can only establish your diagnosis of pleural effusion by doing lateral decubitus. This one, the affected side would be the left costophrenic angle. It's being obscured or blunting of your left costophrenic sinus or angle. So you would request for left lateral decubitus for you to establish your diagnosis of pleural effusion left. Okay? So this one would be diffuse ileus. So again, you could see dilated bowel loops. That one will be your large intestine, and some gas here would be most likely your small intestines. Okay? Again, all these four signs are not pathognomonic to acute pancreatitis. Still, we would request for what? Aside from radiographic examination, for you to establish acute pancreatitis, what would you request? Laboratory, specifically your amylase. Okay? But with your history, what is the most important that you have to elicit in your history? Okay? And then, alcohol intake. Okay? This one would be small bowel obstruction. Okay? So definitely, this air fluid here would be your gastric bubble. It's seen just right below your left hemidiaphragm. So this one is located at the center of your abdomen. This is your vertebra. So a small bowel is located centrally. So you know that this film is taken upright. Why? Because of the air fluid level. Meron siyang air fluid level. Parang may straight line siya at the bottom. Unlike dito, ito gas ito sa may sacral area. So, wala siyang air fluid level. Okay? Here, dilated loops of your small bowel. Because the dilated bowel loops is located centrally, so this would be your colon on your sacral area. This could probably the sigmoid or your rectum. Okay? There you are. Again, nasa gitna yung dilated bowel loops nyo. So this is a case of a small bowel obstruction. So there you are. This is the upright view. Meron siyang air fluid level. You see the difference? This is taken supine. Nakahiga yung pasyente dito. Dito, nakatayo. Okay? Air would go up, fluid would go down. Kaya tinawag natin air fluid level. Okay? There you are. Now, you could appreciate the valvular conniventes. There you are. Can you see? So, this is what you call your coil spring sign. Okay? This is a film of your KU IBP. This is a film of your IBP. Why? The bladder is opacified. So the contrast material is mixed with your urine. So the white one is the bladder area. And within the bladder, urine is being contained within your urinary bladder. Okay? So with the last film, usually, we would request the post-void film. Okay? So as I've said, the patient probably is suffering or experiencing pain. Probably there is an obstruction. That's why meron siyang ileus. You cannot say that this is a small bowel obstruction. Okay? Not unless you would do your upright film. This should be the upright film, the erect. You would see the air fluid level. So, again, there you are. So this is the same person. Can you see that opacified urinary bladder down? So this is the same person. So may air fluid level. So aside from doing the IBP, the patient is having a small bowel obstruction. Okay? Yeah. You have to request for your upright